A big reason surgery can be so scary is because you feel like you have no control in the process. You arrive at the hospital, a nurse starts an IV, the anesthesiologist gives you drugs to knock you out, the surgical team does their thing, and then you wake up in the recovery room with no memory of any of it. Relinquishing control like this is unnerving. It requires that we literally trust our lives to people who are usually strangers to us, and that's not easy or a natural thing to do. And even though we can't direct the details of the procedure itself, having surgery shouldn't be a passive experience. In fact, one of the most important determinants of the outcome after surgery is completely under your control. Not your surgeon, the hospital, or your physical therapist, you. Since the 90s, study after study has shown that expectations are a key factor predicting satisfaction and results after surgery. This is especially true in orthopedics, which is surgery of the musculoskeletal system, and it's been widely demonstrated in spine procedures, shoulder rotator cuff repairs, knee replacement, and hip replacement. In other words, what we expect to happen shapes how well we do. And this isn't just another pitch for the power of positive thinking. Yes, there's evidence to show an optimistic outlook is preferable to having negative expectations about surgery, but there's also a limit to the positivity we should approach surgery because other studies have shown that patients with extremely high expectations are ultimately less satisfied with the results. And this suggests that unmitigated optimism is actually detrimental to how you do. So how can this be? What's actually going on here? This 2017 review will analyze the existing literature about surgery expectations to resolve this contradiction. The authors categorized the studies into two different groups, one that looked at preoperative expectations about surgical outcomes compared to postoperative psychosocial results like satisfaction, levels of distress, regret, and overall quality of life. They referred to these as expectation-only studies. The second group, which they called the expectation comparison studies, looked at the same things, preoperative expectations and postoperative psychosocial results, but with an additional comparison to actual surgical outcomes, like predicted surgical recovery time versus the real recovery time, or expected pain relief or mobility levels compared to what was actually achieved. And this distinction between expectation-only and expectation comparison studies reveals a striking divide. The expectation-only studies consistently showed a positive correlation between expectations and outcomes. So this format supports the idea that having an optimistic outlook before surgery is associated with increased satisfaction after surgery. In contrast, the expectation comparison group of studies showed that unfulfilled expectations were associated with dissatisfaction, greater distress, more regret, and lower health quality of life scores. The authors conclude that as a whole, the evidence strongly supports an association between optimistic expectations and positive outcomes following surgery if, and this is a big if those expectations are based in reality. To state it differently, unrealistic preoperative optimism is a postoperative liability, and this expectation comparison scenario applies to everyday life. It's been referred to as the expectation actualization or expectation reality gap. So the larger the gap between what we expect and reality, or the actual outcome of an event, the more likely we are to be dissatisfied, distressed, or regretful. Here's an example. I'm a huge Mariners fan, but the Mariners are the only team in Major League Baseball that have never won a World Series and never even been to a World Series. So every year when spring training rolls around, I'm hopeful that they'll have a competitive team, but I don't expect them to make the playoffs. So I've learned that if I approach the season with low expectation, then there's no gap, so I'm much less likely to be disappointed. When it comes to having an operation, we have a small amount of influence on the actualization component. We can follow our surgeon's instructions, we can be diligent with physical therapy, but we do have to let go and trust our surgical team to do a good job. So there's an undeniable limit to how much we can bump the actualization part up. But we do have complete control over the expectations that we bring to the experience. And the best way to do this is to get very clear on what we want or hope to have happen as a result of surgery. We have to identify what our primary motivation is for having it, and then write them down. In one column, put your hopes and wants, and make a second column labeled expectations. Then take this with you when you meet with a surgeon and ask them if these things can be achieved with the procedure. Is it reasonable to move the things in your hope column over into the expectation column? And when you're making a list, try to be as precise as possible. Rather than making general statements like, I hope to have less pain or I want to jog, try to define specific desires like, at 4 weeks, I want to be able to walk 2 miles, or my eventual goal is to get back to running 20 miles per week. And be exhaustive with the list as well. What things are you currently unable to do that you want to be able to do again? Maybe you have bucket list items that you've never done before, but you want to have the option to do in the future, like skydiving or hiking the Pacific Crest Trail. The more detailed you can be with the questions you ask ahead of time, the better equipped you will be with quality information to help optimize your outcome. And it's smart to have this list ready at the first or second meeting with your surgeon. It can help guide you and your surgical team and maybe even help you decide whether surgery is the right choice for you. If instead you make assumptions about what's going to happen and then don't find out until later at the preoperative appointment a couple days before surgery, or even worse, after the fact, when you realize your surgery results aren't matching up to what you expected ahead of time, then you're much more likely to be unhappy or to have regret. As a hip specialist, I once saw a young dancer who happened to mention during our first visit together that the primary reason she wanted to have surgery to address an injured labrum was so that she'd be able to do the splits without pain. And she was super disappointed when I said that I didn't think that this was a realistic thing that could be guaranteed. And it was based on this study where a group of dancers underwent MRI scans while sitting in the splits position. The labrum is effectively a gasket that surrounds the rim of the socket. The images from the study showed that in this degree of hip flexion, basically the labrum was getting pinched between the neck of the femur and the rim. And in some of the dancers, the ball portion of the joint, the femoral head, was even sliding slightly out of socket. So even if you have surgery and the labrum heals, it can continue to be painful from repeatedly getting crushed between those bony surfaces. Regardless of that, in her world, surrounded by other flexible dancers, being able to do the splits is a given. From my perspective as a surgeon, the splits is considered a pretty extreme hip position. It hadn't honestly occurred to me that someone might expect that as a result from their surgery. And so I didn't expect her expectations. And I have to say that it was so valuable that she had brought this up at that appointment, because it was a perfect reset for both of us. I learned that I needed to be better about probing with questions what patients were expecting or hoping to get from surgery, and then to educate appropriately according to that. And so when this gal eventually did come back and decide to have surgery, she did extremely well. And I think it was in large part due to the fact that we were in closer alignment with our expectations. We had narrowed that expectation-reality gap. It's important to mention that even though pain, or the desire for relief from pain, more accurately, is a reason that many people choose to have surgery, you need to be cautious about pinning too much hope on the possibility that surgery will alleviate pain. In many of the studies, failure to meet expectations, specifically with regard to pain, was a key source of dissatisfaction. In this one, looking at the results of spine surgery, roughly 40% of patients were overly optimistic in their expectations regarding improvement in leg and back pain. In another study, pain was the number one reason the patients chose to have knee replacement, and 85% expected to have complete pain relief. But this hope was only fulfilled in 43% of the group at 2 years. Similarly, in active adults who had undergone hip impingement surgery, expectations about their hip pain were not met in 56% of the patients at 12 months after surgery. Keep in mind that surgery itself is an injury to the body that leaves an unavoidable imprint. So although it's really hard to hear, if pain is your primary motivator to have surgery, be very cautious in trying to set realistic expectations ahead of time. And when you talk with your surgeon about this, instead of asking about specific pain levels, which are actually impossible to predict because no two people experience an injury or a procedure in exactly the same way, a better way to frame the conversation is to ask, from what you see structurally on physical exam and in imaging, do you think there's a good chance that surgery could help me? And if so, how much? See if they can give you a ballpark percentage based on their personal experience and their knowledge of the literature. And then with all this information that you've gathered, it's up to the two of you and your support team to decide, are the relative risks and uncertainties worth the potential benefit? And if you do opt to go ahead, I'll reiterate the advice of these authors that said, in anticipation of surgery, clinicians and patients should try to balance positivity with practicality and hope with realism. They recommend a good attitude to adopt is cheerful realism. I think we all could benefit from a healthy dose of cheerful realism. Take good care. I wish you well, and I'll see you soon.